I'm starting my case conference. My Indus patient is a 26 years old, single Hindu female, educated till class 12. Currently, she's pursuing a bachelor BBA on honors in first year. She's second in order of two siblings, belonging to upper middle socioeconomic status, resident of Clement Town, Dehradun. She has a BMI of 21.1, that is normal. She's admitted to the hospital on 10th of February 2022 via voluntary independent admission under the Section 86 of Mental Health Care Act. Her identification marks are there is a hyperpigmented linear scar of about 5 centimeter on the left elbow, 3 centimeters lateral to the oliguranon process. And the second identification mark is a black mole of 2.5 centimeter diameter, 1.5 inches lateral to the oliguranon fossa. So the history is reliable and adequate and is given by the mother who is staying with the patient and the patient herself. The illness is predisposed by family history of unspecified psychotic illness in the maternal aunt and the first cousin of the patient. The precipitating factor is in 2012, the academic underachievement of the patient of not being able to get science and math, which were her preferred subjects, in class 11th. And the perpetuating factor is poor compliance to medication due to frequent side effects to medications. The complaints are incidence in onset, continuous and deteriorating, continuous in course and deteriorating in progress, with complaints of decreased social interaction, irritable behavior, decreased self-care, suspiciousness, and self-muttering since last 11 years, and the complaints are increased and aggravated since last 2 weeks. History of present illness. Patient was apparently well 11 years back in 2011 when her class 10th results came, and according to the result, she was not being able to get her preferred subjects that were maths and science for class 11 and 12, and she was getting only arts stream. The patient was not happy with this, and she became withdrawn from his friends, stopped going to school, and most of the time she used to stay in her room almost all the time. She stopped going out with friends and avoided going out with her family members, as opposed to earlier when she used to go out with friends and family often. She stopped going to family functions and preferred to stay alone in her room all the time. In fact, she started having food alone, and she stopped sharing family meals with the family members, and she started having food alone in her room alone. And instead, she used to have food at night when everybody else used to sleep. She would then get up late in the morning at around 11 a.m. She would then get up at 11 a.m. She would often avoid meeting guests who visits her home. She would not talk to the family members or even the guests as earlier. She would even not talk to her parents or a younger sister. And when they used to talk to her and try talking to her, she would become very irritable and be verbally abusive. And sometimes she would also be physically assaulting towards her younger sister. Patient would even stop taking a bath regularly as opposed to earlier when she used to bath regularly. She would, and whenever her parents asked her to take a bath, she would become very irritable. And she would also not show any interest in changing her clothes and wearing her favorite clothes as opposed to earlier. Patient also started being suspicious of her parents and sister and said that whenever they are talking together, she would believe that they are talking derogatory about her. Her parents tried to convince her that it is not so and they're not talking about her, but she would not be convinced, and instead she would become verbally abusive towards them. Her family members tried to convince her at always, but she would not be convinced. Because of all these complaints, her parents took her to a mental health professional in year 2012, but she only took medication for 15 days and then left her medications because she complained of dizziness due to medications. Her family members then took her to another mental health professional in the same year, 2012. This time, she took medications for 2 months under the supervision of her parents. But again, she stopped medication as she said she would feel dizziness after taking the medication. But the patient was started on counseling, and the counseling continued for 1.5 years. After the counseling, there were improvement in symptoms of decreased social interaction, and also irritability was decreased. The patient would now at least sit with her parent, though she doesn't used to talk to them. The complaints continued, and in 2015, the patient was sent to Kota to continue her studies with her younger sister. She completed her 11th and 12th with difficulty, and then she came back home again in 2017. This time, 2017. This time in 2017, her mother noticed that she would often mutter to herself when nobody else was around. And she would often close her ears with her fingers and would become very irritated. Her mother used to ask her that whom she is talking to and is it anything that is bothering her? But she would try to ignore her mother and instead would become very irritable and left the room. Instead of repeated questioning, the patient did not tell anything to her mother. She would often, whenever the patient used to go out, she would feel that other people are talking against her. And she used to be afraid and she didn't used to leave her house. Whenever the patient used to use her phone, she would often complain that there is some camera which is hidden in the phone and the camera is recording her movements. Therefore, she would try to use phone more lesser and lesser by each day. Patient also couldn't concentrate on her studies and altogether left her studies. A patient would also not take care of herself, would not take care of any bathing or brushing. Her condition deteriorated, and in 2019, her parents again took her to a mental health professional, and her medication was started. Since 2019, she had good compliance to medications and is taking them continuously. But in 2019 itself, she had an episode of involuntary body movements for which a medication was started, which I'll tell in the treatment history. And there was also episode of persistent trembling of body and rigidity and tightness of body and tightness of limbs of the body. After that, the medications was changed. She was on continuous medication till now. And the symptoms of self-muttering, suspiciousness, and decreased social interaction improved. But in year 2021, she for 1 month she left consultation with her mental health professional, and the symptoms got aggravated since last 2 weeks of increased irritability, suspiciousness, and decreased interaction with family members, and hence she was brought to the respective hospital. In the treatment history, in year 2012, she was started on risperidone 1 mg, which was increased to 2 mg, which was continued 15 days, but she complained of dizziness. So the compliance to the medication were poor and she stopped medication 15 days. After that, in the same year, 2012, she was started on olanzapine 5 mg at night, along with psychotherapy. The medication was continued for 2 months, after which she herself left the medications as she complained of dizziness due to the medications. The psychotherapy that continued for 1.5 years. After that, the medications were again started in 2019. She took clozapine, which was up titrated to 50 mg. On these medications, she was also on phenobarbital on 60 mg, which was started after the episode of involuntary body movement. She is on good compliance to medications, and the family is also supported towards the medications. In the past history, there is no history of any significant medical or surgical history, except for she had a history of typhoid in class 7th. In the family history, there's history of unspecified psychotic illness in her mother's sister and in the first degree cousin. And there's history of hypothyroidism and bronchitis in mother. The economic head of the family is father and the emotional head of the family is mother. The family is supported towards the illness and towards the patient. In the birth history, the patient is born by the full term vaginal delivery, which was vacuum assisted because of oligohydramnios in the mother. There is no history of any lying, stealing, truancy, attention-seeking behavior, or temper tantrums in childhood. The home atmosphere in childhood and adolescence was cordial, and there is no history of any broken home, step-parent, or adaptive sibling. In the scholastic, in the extracurricular history, she started schooling at 5 years of age in UKG. She was good in studies and she had cordial relation with her peers. In menstrual history, her cycles are regular. Menstrual cycles are regular with last menstrual period on in 11th of February 2022. The flow is normal and there is no history of dysmenorrhea. Sexual history could not be attained by the patient. Forensic history is not reported. In pre-morbid personality, self, the patient was ambitious and she wanted to become a scientist. She would prefer company with her friends and would easily make her friends. In her work and leisure, she likes listening to music, to old songs, listening to old Hindi movies, and she would also like drawing. In mood, her mood is stable and she is non-violent, and she loves to talk to her friends. Her mood is stable and she doesn't lose control of over her feelings. She's religious by nature and often visits temples with her family members. In habit, she has normal bladder bowel habits. Food and sleep cycles are normal. Sleep cycles are normal. On physical examination, there's no pallor or icterus or cyanosis. There's no lymphadenopathy. There's no edema. BP is 120 by 80 and pulse rate is 86 per minute. In cardiovascular examination, normal heart sound 1 and 2 are present in all areas of precordium, and there's no murmurs present. In the respiratory system, the trachea is central. The bilateral vesicular breath sounds are heard with no added sound present. In inspection, there is no history of any dilated veins or organomegaly. The abdomen is soft, non-tender, and bowel sounds are present. And central, there is no sensory neural deficit. There's no sensory neural deficit in the sensory and the CNS central nervous system examination within normal limits. In the mental status examination, she is an average wilt male. She entered the room unaided with her mother. She is wearing a blue-colored jacket with uncombed hair, but her clothes appear clean. And liquid chart में light is not born.
मैं लिख दूँ chart में.
तुम्हारा हिस्ट्री कंप्लीट हो गया ना?
हाँ, मेंटल स्टेटस एग्जामिनेशन कनेक्ट हो गया मैम.
Till now, or questions you can ask. अरे इसका बंद नहीं है ना? क्या किसी ने कुछ Anyone want to clarify history?
Dr. Priya, just tell me one thing, whether did they attempt to change why she was not getting science and maths?
Actually, sir, at that time, her mother said that when it got her 10th results, actually it happened that they were adding both the 9th and the 10th results together. And after that, they calculated the overall percentage. And based on that, she was not getting so science and maths.
Okay, and did they try it in any other school?
Yes, sir. Yes, sir. They did try it. And in another school, she was given science and maths, but she only went there only for 2 months. After that, she stopped going to schools.
Okay, so trying in other school, they couldn't get the desired branch.
Sure, she stopped going to school because of the negative symptoms.
Okay.
Yes,
Okay. But when they attempted, they could get the desired branch.
Yes, sir. Yes, sir. They could get the desired branch.
But before that, only the symptoms started.
Yes, sir. So at the same time, the symptoms started precipitated. Yes.
Okay.
Yes.
Thank you.
Thank you, sir.
We also ask predominant mood. So what is the predominant mood of a patient during the illness?
So she was irritable most of the time, sir.
Okay, fine.
Yes.
Thank you.
Thank you, sir.
Any other questions? So, Dr. Priya, continue with MSc.
Yes, ma'am. In the mental status examination, she's a mesomorphic built female. She entered the room unaided along with her mother. She sat on the chair provided and greeted the examiner. She was wearing a blue jacket and black trousers. She had uncombed hair, though the clothes appeared clean. Deducing that normal grooming and hygiene are not maintained. Her attitude is cooperative, but was evasive. Rapport was established with difficulty. Psychomotor activity was decreased. Speech, tone, intensity was normal, but volume was decreased. Reaction time was increased. Speech was relevant, coherent, and goal-directed. Attention was arousable and sustained. The patient was able to do serial subtraction 100 minus 7 and was also able to count the days or week backwards. She was oriented to time, place, and person and passage of time. In memory, her recent memory, remote memory, and immediate memory were intact. The patient remembered what he had in the morning. She was able to also remember the 4 objects which were asked to her. And she was also able to remember the remote events in her life as cross-examined with the mother. In abstract ability was semi-abstract, as when I asked her what's the meaning of the proverb, Naach na jaane aangan teda, she replied that calm काम नहीं आया करना. And she didn't explain the whole proverb appropriately. And she only told only one difference between orange and apple, and only one similarity between orange and apple. Her general information was adequate, and she was able to tell the Prime Minister of India, the first President of India, and also who is called the Father of Nation. Calculation, she was able to do a simple verbal and written calculations. Based on that, her intelligence was normal. Mood, she replied, "ठीक है." Affect was shallow. Range was full, reactive, and was non-communicable. In thought stream was normal. Form of thought was also normal. Possession was self. In content, the patient was preoccupied with going home, and she preoccupied with discharge, and there was no perceptual disorders, no perceptual abnormalities in the mental status examination. In her judgment, test and social were intact and personal was impaired, with an insight of grade 2. My diagnostic formulation. My patient is a 26-year-old single Hindu female, educated till class 12, currently pursuing BA honors first year, second in order of 2 siblings. She has a BMI of 21.1, which is normal, belonging to upper middle socioeconomic status, resident of Clement Town, Dehradun, admitted to the hospital on 10th of February 2022 under voluntary independent admission in Section 86 of Mental Health Care Act. The history is reliable and adequate. With history given by the mother. It predisposed. The complaints are predisposed by having a positive family history of unspecified psychotic illness in maternal aunt and first cousin, and was precipitated by academic underachievement due to not being able to get her preferred stream in year 2012, and history was perpetuated by poor compliance to medication due to various side effects. The complaints are insidious in onset, continuous in course, and deteriorating in progress, with complaints of decreased social interaction, irritable behavior, decreased self-care, suspiciousness, and self-muttering since year 2011, that is since last 11 years, and the complaints are aggravated since last 2 weeks. The positive mental status examination. The grooming and hygiene was not maintained. The patient rapport was established with difficulty. The psychomotor activity was decreased. Speech, tone, and intensity are normal, but volume is decreased. Reaction time is increased. The abstractability is semi-abstract. Mood was the mood was ठीक है, affect was shallow and non-communicable. The judgment personal was impaired and insight of grade 2. My diagnosis is paranoid schizophrenia. In the management plan, I like to first admit the patient in inpatient department, and I like to send several investigations. Like first, I'll do a history and a thorough mental status examination along with a systemic examination of the patient. And after that, I'll send various investigation. I would like to investigate for the electrocardiogram and the various routine examination like the complete blood count, liver function test, kidney function test, the renal function test, and the thyroid function test. After that, I'll start on antipsychotics, second generation antipsychotics. And along with psychotherapy, I would like to psychoeducate the parents about the illness and about the compliance to medications and about the prognosis of the disease. And I'll try to also give insight-oriented therapy, psychotherapy to the patient so that the insight is improved and the patient takes medications of herself and the compliance is also improved.
Can you enumerate points in favor of your diagnosis, Dr. Priya?
Yes, ma'am. As I said, the illness is a continuous illness, and the illness started way back in year 2011. Since then, the patient is having continuous negative symptoms. The patient is not interacting with the family members. She also left her studies with difficulty. She was able to pass her 11th and 12th, and she doesn't go out with friends, and she doesn't like talking to family members. This is the first thing. And then secondly, ma'am, in the history I could get, like a patient had suspiciousness and to a delusional level about her parents, and also for all other people. She used to believe that the people are talking derogatory about her and passing derogatory comments over her. The parents tried to convince her that it is not so, but she insisted that no, they're actually talking about her and they're talking derogatory about her. But I could not get this in mental state examination. Only according to history, I could get 2 points. So this goes in favor of paranoid schizophrenia because
Diagnosis is according to history.
this is according to ICD-10 now.
Dr. Priya? Hello, Dr. Priya?
Yes, sir.
When you say economical leader and a nominal leader in the family,
Economic head, yes, the economic head is the person who takes care of all the family money, like family expenses, and the emotional head of the family is who takes care of all the emotional decisions of the family, who takes all the emotional decisions. And the economic decisions are usually taken by the economic head, which is father in our case, and the emotional head is mother in our case.
if any family having two economical workers, how will you define the economical leader?
If the economic head is who take care of all the expenses of the family, who actually who's the main decision maker for all the money matters of the family, like, and the emotional.
No, I'm asking.
Yeah.
What you said, this is partially correct, but otherwise we need to concern about who provide food, shelter, clothes to the basic commodities to the patient, and how many dependents related to the function leader along with the family members.
Yes. So the economic head usually provides with the shelter, food, and all such needs.
Yeah.
Yes.
Okay. In family history, there is a lot of psychiatric illness also involved in the family.
Yes. Sir.
Okay, which is also involved in. I also presented previously schizophrenia theories. There is a lot of theories related to history. History also related to the theories.
Yes, sir.
Basically,
In the birth history, she was a vacuum assisted delivery because of oligohydramnios in the mother at that time. There was oligohydramnios in the mother.
okay, when you go into present family history, because you are exam going student, so I'm telling to you, you need to in the family history concern on family leadership, communication, as well as like affective involvement. Okay.
Yes, sir. Yes,
Other,
sir.
what is parenting control, parenting, what are the type of parenting? Everything you need to ask to the
Yes, sir.
family members.
Yes, sir.
And because there are other issues also, you need to consider that.
Yes, sir. Yes.
थोड़ा टाइम चेंज करके इन्फॉर्म कर देते हैं ना ग्रुप में जाना है तो जल्दी कोई मैसेज पड़ता है जरूर पड़ना
There's a question. Please enumerate the specific points of ICD-10, whether major or other minor points that met for the diagnosis. So I have 2 points which met the diagnosis. First of all, delusions. First of all, delusion of preference was present, and the second point is persistent negative symptoms persisting for the last 11 years. So the 2 points are met for the diagnosis of schizophrenia.
The point for delusions are specifically in ABCD. Delusion of preference, for that to meet, you require with that the criteria E, you require some hallucinations also. Only delusion will not be sufficient.
Yes, sir. So there's history of self-muttering is present, but the patient is evasive and she refuses any auditory hallucinations. But in history, her mother reports that there's history of self-muttering, and she would often talk to herself while roaming inside the home, and she also used to close her ears, both ears, with fingers, and used to become irritated. But in some
that means we have only one criteria that meets the diagnosis. That is which one you say? The negative symptoms.
yes, sir, negative symptoms were present. Sir. They're still present. Sir.
And what is your diagnosis?
So paranoid schizophrenia.
Negative symptoms are going by your, like, I've not heard the whole case, just by the diagnostic formulation.
Yes, sir.
You are saying negative symptoms are predominant. Okay.
Yes.
Hallucinations are question mark. No, you have not
Yes, sir.
established.
Yes, sir.
And delusions are there.
Yes,
So
sir.
it will be difficult to defend the diagnosis of paranoid schizophrenia. Why not undifferentiated? Because you don't know what will come up.
So because
Anyway, schizophrenia is one.
Yes,
Any
sir.
other diagnosis you are entertaining?
So no, sir.
Because like your assessment is still pending, you can entertain a diagnosis of F28 non-organic psychosis also if the criteria of schizophrenia are not met. Then that is also one
Yes, sir.
diagnosis where there are non-specific psychotic symptoms. So
Yes,
why
sir.
can't that be a differential?
Yes. Sir.
Anyway, that's all from my side.
Yes, sir. Thank you, sir.
Any comments or queries? So should we add that?
पता नहीं मैं तो मॉडरेट कर लेगा जो मॉडरेट करूँ
Sir. So we discussed a case of adolescent female who developed the illness in adolescence while she was in 11th or 12th standard, and which started with negative symptoms, and maybe could be prodrome was present in initial phase, and then afterwards she developed positive symptoms, and and it's a long duration illness, and which responded well on second generation antipsychotics. So
Depression with psychosis तो नहीं है आपको पकड़ी अगर started with negative symptoms postman में starting
So, it was like there were no depressive features at that time, no crying spells, no reported depressive cognition from the patient side, or which could like suggest towards that. So,
addiction क्या है
So decreased social interactions, used to stay alone. She then used to share the meals with family members as opposed to earlier. Then she would not take a bath and she would not even change her clothes. Until unless repeated insistence by the family members. And she would also stop going office and stopped her school also. So stop going to school also.
ठीक है anyways आपने कंक्लूड कर लिया तो मतलब उसने नॉर्मली मतलब आपके एमएससी में जितनी बार भी हुआ है प्रीवियस रिकॉर्ड में मूड कैसा रहा मूड और
So mood was irritable. So most of the predominant mood was irritable.
मतलब फर्स्ट ऑफ सिम्टम है यही द डिक्रीज इंटरेक्शन ठीक
so here we will be ending our conference. Thank you. Okay.